Some of us call ourselves doctors for orthopedic medicine, maybe a physiatrist among us, rehabilitation medicine, a couple of sport medicine, or orthopedic surgeons. So it's a wide variety of things. But what do? We treat musculoskeletal injuries. And if you treat musculoskeletal injuries, your agenda probably looks like this. So it's pretty. There's a high demand for it, especially in the Netherlands. And if your agenda or if your schedule look like this, then you probably look like this too. So, which is going to do a couple of quick and easy cases that I have encountered in the last couple of weeks or months. So there we go. Case number one is a 38-year-old man. He's a plasterer, so he does this, he plasters the walls all day long. Basically, he works in construction. Otherwise, he's very healthy, he doesn't even smoke. But he's got a pretty nasty problem, and that is that he's not been able to work for a year. And he's also not able to sleep on his shoulder. And where exactly does he have pain? He said, I've got this terrible pain on the back of my scapula. It's on the left side.
There you go, Adrian.
And also some tingling and numbness down the arm and down the hand. He says, sometimes at the end of the day, I have such terrible pain, I can't sleep. It's horrible. I'm not so good at drawing, so I looked up on the internet pictures that might, look a little bit like it. So actually, the pain was more on the back of the scapula and also down the arm. In the rhomboid region, not so much, and the neck region also not so much. But this approximated quite well. Of course, we know all these charts of the these trigger points charts with the diverse referral patterns. Okay, so he had already been to a physical therapist. He did some exercises, didn't get better. He went to an orthopedic surgeon. He did an ultrasound of the shoulder. Nothing really remarkable. He also went to see a neurologist. And there was an MRI made of the cervical spine. Nothing crazy. He had a disc bulging on the L4, L5, but it was on the wrong side. So he said, yeah, it can't really be that, so we don't know what it is.
You mean lumbar L4 or C4?
So, sorry, the C4, yes, excuse me. So he came in to us and we said, all right, let's take a look. So we did a physical exam. This is just a quickly, I can go in depth, of course, but I don't have the time for that today. So started off with an examination of the cervical spine, nothing really remarkable. Thoracic spine, that's what I basically thought. I have to check this first because it sounded to me a little bit like maybe a thoracic facet problem that gives pain at the back of the scapula, that region. But there's nothing really remarkable as well. We looked at the alignment of the spine and it was pretty good. Then I always do the Ceriax, what I call the Ceriax shoulder examination. I really love the way that Ceriax put it up, the methodical way of thinking. So active and passive range of motion. There was nothing wrong with him. He could raise his arms, no problem. Resistance tests, no problem at all. Impingement tests, nothing. The neurological exam was also quite good, nothing wrong. So I thought, what is this? Now, then we come to the most, in my eyes, sometimes the most important part of a physical exam, and that is the palpation. So I palpated the patient, and the muscles on the scapula were very tender. He said, oh yes, I recognize this. But when I came to the rotator cuff, he almost jumped up, it was very, very, very tender. So, let me just go back just 1 second. So I thought, what is the diagnosis? Can it be that simple, that it's just a rotator cuff tendinitis or tendinosis, however you like to call it? Because usually with the Ceriax exam, you see the painful arc, with the active range of motion. They can't really, they have to go over a hump. The resistance tests, they're usually positive, like for the supraspinatus, you've got the abduction, or for the infraspinatus, the exorotation that is painful. The exorotation against resistance, I mean. Impingement tests are usually also positive when you provoke a swollen tendon or something. So I thought it was weird. It was a little bit funny. So I thought, let's treat him anyway. Just to say, let's treat the patient. So the first injection I did was actually here on the supraspinatus tendon. I used a concentration of 20% of glucose, dextrose, with 0.5% of lidocaine. So I put the needle in, and the patient said, oh my God, I feel tingling and pain down my arm. Usually when patients say that, I get nervous, right? So But in this case, I'm actually quite happy about it because I knew my spot of the injection and I provoked the patient's pain. Then when I came to the infraspinate, it's the same stuff. And he said, oh, now I feel more on the back of my arm going down. And I said, yes, you know, we're in the money here. Also, diverse trigger points on the scapula were quite painful. And what people often say is that they feel a heavy and numb feeling down the arm when they treated there in that area. So I thought it was very interesting. And I treated him for, I believe, 6 or 7 times. He's a lot better now. He's very happy. So that was case number 1. Case number 2, and I know Stephen will talk about this problem, trouble, leg pain or trouble in the leg after a knee replacement surgery. So a lady came to me, 71-year-old, quite healthy for their age, no medication what to speak of, except some paracetamol for her current trouble. And she came to me with pain in the right thigh area, numbness, tingling, sudden electric jolts, and also pain when you rub it, so allodynia. She couldn't really have pants on, she didn't like that as much, so she wore like robes or skirts. And she came to me in the beginning of the year, so it's cold in the Netherlands, right? So she was not happy wearing skirts in the middle of winter. So here we see the scar, obviously of the knee replacement. And where did she feel pain? Where did she say, well, not really pain, it's also numbness and all these other symptoms. Where was it? It kind of started up here, went down and it stopped above the knee, and it also crossed over the midline, a little bit to the medial side as well. It was quite a big, and it wasn't the same every day, you know. Sometimes the numb was down here, and here was a numb spot, and there was like tingling over there. So first I thought, okay, this sounds a little bit like parastatic neuralgia, right? So where the lateral femoral cutaneous nerve gets pinched here in the inguinal, under the inguinal ligament. But that didn't really explain why these sensations also crossed over the midline. So I thought, yeah, well, what is it? I couldn't really narrow it down to one nerve, so probably it was multiple nerves going on there. So, of course, this is one other chart of the superficial nerves, and here's another one. So it was probably like a combination of nerves, and yeah, what it had to do with the knee replacement surgery. She said it came like days after, so it probably does have a causational effect, whether it was the operation itself or maybe the position she was in during the operation or what else.
The suturing and so on.
Something like that, yes.
Entrapments.
Entrapments. But funnily enough, she did not have any pain over the kneecap or any of these neurological symptoms there. So I also found it very hard to palpate on her because some areas were also numb, so she couldn't really give me this feedback that I was really on the nerve. So what I did, I call this the neuroprolotherapy for dummies technique. I just did a big grid. Yeah. So, because I couldn't really point it down so much, so I thought I have to do something for this lady. And I just treated the whole area with D5W in a somewhat roster-like way. And, well, she said, well, the area started to shrink, basically. And it's also not really confined to a specific nerve pattern. It's a very interesting case. So, after 4 treatments, she said, oh, I'm getting a lot better, and I'm happy, and stuff like this. And on the 5th time she came back, and she said, Doctor, no, the treatment did not work. I have pain, the pain got worse. Yeah, no, the treatment didn't work. I said, okay, but tell me what happened. Yeah, nothing happened, no. So I thought, well, think really hard. Has there been a moment that you experienced more pain? Yeah, no, it's nothing strange. Yeah, well, maybe, yes. So this lady, she has a Rhodesian Ridgeback. And if you know dogs, it looks a little bit like this dog, but I found this picture funny because he looks very guilty, right? So I thought it was suitable. So this lady is a quite short lady, has a Rhodesian Ridgeback, and their tails are really thick. And they're almost like rubber batons, like the police use, right? So, but the dog gets very excited when they go out to walk. So when she's in the hallway and she needs to put on the leash, the dog's like wagging his tail to her leg and basically just smashing up all the nerves. So I said, well, you need to find a solution to this. So she did. We resumed the treatments, and she's a lot better. She actually, it's not completely over yet. She's currently also under treatment still, but we're going the right way. Case number 3. So a 68-year-old female, slightly overweight, type 2 diabetes. She does use metformin for this. She has a very sedentary life. I think she's severely sarcopenic as well. She cannot walk for more than 100 meters without having to sit down, basically. And she complained with bilateral medial knee pain. So this type of case with this type of usually women, and usually the same type of, this how do you call it, like archetype or something, we see a lot in the practice, a lot. So this is a very recognizable thing. She got an intra-articular cortisone shot in the hospital at the orthopedic surgeon. No change whatsoever, also not short-term or anything. So we examined her. The flexion and extension was on both knees was actually quite good. There was just a slight medial instability, but what was very, very significant or very remarkable was the swelling on the medial knee. Now remember, this lady is already slightly overweight, so there is some fat tissue there as well, but it was so swollen and it almost started to hang over. It was really remarkable and extremely painful on palpation. And again, we aggravated or we provoked her specific pain. That I say, well, if I press here, does this make your pain better? Yes, yes, yes. Okay, so I narrowed down to maybe a few structures. So the pes anserinus, we all know, there's also a bursa between the pes anserinus and the medial joint line or the medial collateral ligament. And also very important in this area is the saphenous nerve. So this is just an easy or a quick picture of how it looks like. Of course, we've got here the sartorius, the gracilis, and the semitendinosus attaching here to the medial tibia. Over here, the medial collateral ligaments as well. Under that, I must say, the medial joint line itself in this patient was it wasn't really this portion that was painful, was really more like under here. And obviously also the saphenous nerve that runs there that can, dump all these neurochemicals in there and cause pain and swelling. So, again, it's probably a combination of things. So, but why, right, we look back, why is this such a common problem that we see? Does it have any biomechanical reasons? This is another picture there. Oh yeah, just first the treatment. So what do? I treated her with the standard prolotherapy routine, the entire knee routine on both sides. She got better, but not completely. I think around about 30%, 40% better max. A lot better than that. I don't think I am able to get there with prolotherapy, or even, who knows. So, is there any biomechanical reason for this? Why is there so much stress put on the medial joint line, or even on the tissue there? So, this part of the explanation, and where we always look at, is at this syndrome. This chart I absolutely love. So we use this chart in basically all our patients. We can hang up this, whether people come with a shoulder problem or neck pain, or lumbosacral pain, or knee pain, or foot pain, or shin splints, or whatever, we can usually fit it in this picture, and that's how we look at it as well. It's called the malalignment syndrome, and there is a Canadian sports medicine doctor, Dr. Wolf Schamberger, who has written this book, and it's extreme. I recommend this to everybody. So what we look at this lady, because I think because of her sedentary lifestyle and in her weak general musculature, she got a terrible blocked SI joint. So if the SI joint does not move properly during gait, and if she has weak gluteal muscles, that causes internal rotation of the knee. In this case, in this chart, it's unilateral then, but it causes, if the SI joint is turned in like this, it causes the knee to bend, internally rotate, and then also the pronation of the foot, and it gives stress, and it gives all kinds of strange muscle patterns in order for her to do just a regular walking. So this is what we looked at. We corrected also her chiropractically with the Thompson technique. I'm not going to get into that too much here on this slide or in this presentation, but we corrected her SI joint, and then that also relieves some pressure on the knees. So that's the book I would recommend. Thank you very much.
All righty, you have 5 minutes for questions, okay? We have a question in the back, and then we have one over here. Okay. So Lenny.
So a lot of that in my practice, and most of these older women, men, had hidden varicose engorgement on the saphenous vein, which pressed upon the saphenous nerve, which then sent its signal to the knee. So I would just use a very simple D5W nerve block at the saphenous at that particular area, and then put a compression socks on, and they did very well. Thank you.
Okay. You want to say something,
So I'm an orthopedic surgeon, so it was very interesting in the case of the failure of knee replacement, the pain on the knee replacement, because I think I'm an orthopedic surgeon, so I think my colleagues will kick me and fight me. There is an overuse of knee replacement, I think. There are much colleagues that put knee replacement in every, I think, first grade, 2nd grade of arthritis, and I've seen 3rd grade, 4th grade arthritis, and I didn't make indication for knee replacement. I try many roads to, and the problem is that when you perform knee replacement, you have cases like that, the damage is done sometimes, so it's very difficult to manage. And I can understand your difficulty to that. Me too. Sometimes I cannot make, I don't have so clear solutions for that.
Just one point. For knee replacement, when they have pain, assess for the patella articulation, because quite a lot of cases are pain due to the femoral patella, and it can be accessible with prolotherapy, even if they have the knee replacement done.
Yeah, there are so many answers to this. Very quickly.
I have 3 questions. Thank you very much. First of all, I think excellent presentation. In the case number 1, with the shoulder pain, I will always take a look on the lungs, Pancoast tumor, lung cancer, and I think a chest X-ray is very important to, especially the patient is a smoker, even if he's 32 years old, in your case. In the case of the knee replacement, I see very often that leg discrepancy develop after a result of the knee or hip replacements, and when this happens, then all muscles on the longer side activated and could produce a pain, reflection pain, as a consequences of leg discrepancy, because tilt of the pelvis will activate gluteus medius, all abductor piriformis, obturator externus to correct pelvic position, and it will cause a pain, like ITDS syndrome. So standing X-ray, standing bare feet X-ray, lumbar spine, pelvic, will give some idea about this. So this is, and the last one, I agree. Maybe the major factor is the hyperpronation of the foot. What she had on X-ray, hyperpronation of the foot induced internal rotation of the tibia, strain of the MCL, and as a consequences, activation of the pes anserinus to stabilize medial collateral ligament and sacral leg joint. All this chain, which you will see nicely described in the book of malalignment syndrome.
Thank you.
Excellent. Bjorn, that was awesome. I just have to say that you are a natural Bjorn presenter. So, but anyway, so you can tell how awake the crowd is when you don't hear any. So with the second case, with that kind of unusual paresthetic sort of thing, I've seen probably 3 or 4 cases over a long period of time. I don't see these too often, maybe over like a decade. of this after not just knee replacement, but some type of lower extremity surgery. And what it appears to be, or a significant influencing factor, is the tourniquet. It's the tourniquet. That really seems to be the causative factor in a lot of these cases. And it's something you don't think about, right? But I remember the first case of this that I saw, which was actually more than 10 years ago, and it was actually bilateral on this guy. And what I find is that the causative, or the sort of pathology, is that the fascial layer, traditional prolotherapy approaches don't seem to work particularly well for this. And believe me, I've tried. I find that having to look for those fascial defects and injuries under ultrasound based on your palpatory diagnostics. So I use prolotherapy technique in terms of the palpatory diagnostics, very helpful, but then I have to use the ultrasound to really isolate where that injury is, because most of the time it is less than 1 millimeter in terms of where that injury is, and it can be fairly diffuse because of the nature of the tourniquet, and the pressure causes fascial shearing and all this kind of stuff. And once you isolate that and knock it out, it can help. Usually I'm not able to completely eliminate it though. And so I think that the perineural technique that Bjorn did is very, very helpful for stuff like this if you do not have ultrasound available to you.
So you do, I'll do it, you just change, tell me, I'll change slides. Okay. You just say next. Okay, I know there's one more question, and because we just prepared him, Dr. Yoon.
I have two comments. Number one comment is all of the prolotherapists and all of the surgeons, they miss the scapula. So very simple method to check the scapula winging is this way. This is your elbow extension and your wrist extension, and move like this way. Okay, okay. Long thrashing nerve dysfunction or scapular winging. Very simple method. And number two, if the patient has both knee pain, medial side, and over the 65 or over the 50, you need to check the atherosclerosis, both sides. Yeah, I have many patients nowadays. I don't know why. COVID-19 or vaccination, I don't know why. But I have many patients of the atherosclerosis nowadays. It's the real world. I have several tons of 20 or 30 or over the 100 cases of the atherosclerosis. It is very, very important. So you need to check the X-ray in the lumbar, AP, and lateral. If you check the X-ray, lumbar, lateral, and you can identify the atherosclerosis in the abdominal aorta, it is very important part. Yeah, atherosclerosis, you need to take something, or you need to inject to the aorta, something. Okay, it's not a joke. Okay, I simply inject the D5W or the PRP or stem cell to the aorta and the Karaman carotid artery. It's the real. Yeah, I can solve the problem. So, oh yeah, it's not a big deal. It's very easy.
You did me. You don't want to prepare a coffin. Okay. Okay, that was excellent. Now we have presenter is going to speak about